Hello and welcome to the Emirates Society of Emergency Medicine Emergency Ultrasound Lecture Series. My name is Rasha Bohmaid, and in this presentation we will be talking about the use of point-of-care ultrasound to evaluate abdominal aortic aneurysm. Let's start up with a case. This is a 69-year-old male who presents to the emergency department with epigastric pain for the past 4 hours. He had similar attacks in the past few years, but usually they last for 2 to 3 days. This time, the pain was more severe and it was associated with vomiting, therefore he came to the emergency department. He has a history of smoking, but no other medical problems. His vital signs reveal that he was hypotensive with a blood pressure of 92/69 and the rest of the vital signs as shown. The differential diagnosis in this patient is broad. Abdominal aortic aneurysm is one of the potential differential diagnoses. Abdominal aortic aneurysm should be suspected in any patient 60 years or older with complaints of abdominal pain or back pain, particularly if they have a history of hypertension or smoking. Emergency bedside ultrasonography enables the physician to confirm a high-risk diagnosis, decrease the time needed to mobilize resources, or even transfer the patient to a referral center if necessary. This one exam will save lives incorporated into the regular practice of physicians involved in the evaluation of acutely ill patients. The objectives of this talk include review a background on abdominal aortic aneurysm, relative anatomy, and then we will focus on the indication and the technique of performing an abdominal aortic aneurysm scan. What is the literature evidence-based supporting the use of this ultrasound exam? The limitations and pitfalls, and finally, review some ultrasound protocols of how to incorporate this scan into your clinical practice. The incidence of abdominal aortic aneurysm has been reported to be as high as 36.2 per 100,000 and is increasing. Up to 62% of patients with ruptured aneurysm die before reaching the hospital, and the overall mortality rate is close to 90%. Mortality significantly is reduced with screening and elective repair. The risk factors for abdominal aortic aneurysm are similar to risk factors for atherosclerosis, including smoking, male gender, elderly, history of hypertension and hyperlipidemia, as well as family history of abdominal aortic aneurysm due to either genetic or environmental factors. There is no disease more conducive to clinical humanity than aneurysm of the aorta. This is a quote by William Osler. He is a Canadian physician and one of the founding professors of Johns Hopkins Hospital. His words still resonate today despite the remarkable advances in medicine since his time. So you should scan for abdominal aortic aneurysm, obviously in any patient you are suspicious that could have a AAA. One high-risk group includes older males with hypertension and a history of tobacco use. Usually, patients are asymptomatic until they expand or rupture. And at that time, they can present with pain, either can be low back, flank, abdominal, or groin pain. Classically, it's sudden and severe, and often associated with nausea or vomiting. Ruptured aneurysm will present with shock, hypotension, tachycardia, syncope, altered mental status, or cardiovascular collapse. We were taught in medical school to evaluate for pulsatile mass when we are suspicious of abdominal aortic aneurysm. So how good are we? Virtually, if you palpate abdominal aortic mass, it's diagnostic, but it's only present in less than 50%. The classic triad of hypotension, tachycardia, as well as pulsatile abdominal mass is present in less than 30 to 50% of cases. So we know that we can't really rely on physical exam to exclude abdominal aortic aneurysm. So how good are we clinically? It has been reported that the initial misdiagnosis rate of a AAA is up to 24 to 42%. And the physician palpation of a mass is reported to be 30% when the aneurysm is between 3 to 4 centimeters, 50% when this aneurysm is 4 to 5 centimeters, and goes up to 76 when the aneurysm is greater than 5 centimeters. So not really very good or sensitive. These numbers reflect that clearly our physical exam is not accurate. The most common misdiagnosis is renal colic. That's because either the aneurysm can cause dissection of the renal artery, or the expanding aneurysm can compress the ureters and can cause hydronephrosis. This is a representative CT scan showing an abdominal aortic aneurysm causing a retroperitoneal bleed, and that is compressing the ureters posteriorly, leading to hydronephrosis, and therefore the patient can present with flank pain. So remember, elderly patients or males greater than 65 years old with flank pain, always think of abdominal aortic aneurysm in your differential diagnosis. The natural history of abdominal aortic aneurysm, the average growth is reported to be 0.2 to 0.5 centimeters per year. Large aneurysms expand more quickly than smaller ones. Significant abdominal aortic aneurysm that are high risk for rupture are usually the ones that are greater than 5 centimeters in diameter and they're fusiform shaped. Much research has been done to correlate the diameter of the abdominal aortic aneurysm and the risk of rupture. As you can see in this table, that the larger the size of the abdominal aortic aneurysm, the higher risk of rupture per year. This is a representative slide that shows the location of the abdominal aortic aneurysm. It's important to note that it is located just anterior to the vertebral body. This is an important landmark that we will be using to understand how to ultrasound the patient and interpret the ultrasound images. Reviewing the anatomy of the abdominal aorta is important to understand the ultrasound exam. The abdominal aorta enters the abdomen through the diaphragm just inferior to the xiphoid process and bifurcates around the level of the umbilicus. It has a predictable series of branches as pictured. The first branch of the abdominal aorta is the celiac trunk. The celiac trunk divides into 3 vessels, although typically only the hepatic artery and the splenic artery are reliably visualized. The second branch of the abdominal aorta is the superior mesenteric artery, typically 1 centimeter caudal to the celiac trunk. The SMA runs parallel to the abdominal aorta and can be tracked caudally with the abdominal aorta. While the renal arteries may be visualized, the branches of the gonadal and inferior mesenteric arteries are not typically seen with ultrasound. The abdominal aorta ultimately bifurcates into the common iliac vessels around the level of the umbilicus. The normal abdominal aorta has a proximal to distal taper, and the loss of that taper with a diameter greater than 3 cm indicates the presence of an aneurysm. An iliac diameter of greater than 1.5 cm is indicative of an iliac aneurysm. It's important to look for the abdominal aorta in the most common area, which is known as the AAA zone, which is the infrarenal. More than 95% of abdominal aortic aneurysms are infrarenal. To perform this study, you will use the standard curvilinear or abdominal transducer. The abdominal aorta can usually be visualized entirely down to the iliacs. The curvilinear array probe will often give the best penetration, especially in patients with a larger body habitus. If you only have the phased array probe, you can use that as an alternative to the abdominal probe. To perform the abdominal aortic aneurysm scan, we recommend that the entire length of the abdominal aorta should be imaged in real time for a complete exam. In order to document these findings, it is helpful to especially image the following 5 areas: the transverse view of the proximal aorta, a transverse view of the mid-aorta, a transverse view of the distal aorta, and a transverse view of the distal aorta showing the bifurcation into the common iliac arteries. And finally, a longitudinal view of the abdominal aorta. So remember, these are the 5 key elements where you should examine and measure the abdominal aorta. The most important anatomical landmark to find the abdominal aorta is to look for the vertebral body shadow. The vertebral body is this white line with a posterior black shadow, and just anterior to the vertebral body is the abdominal aorta. Remember that both the aorta and the vena cava will be just anterior to the vertebra. The aorta will be a bright white circle filled with black located right on top of the vertebral body. One common mistake is to set the depth on the ultrasound machine too shallow to find the vertebra. It is recommended to set the depth as deep as the machine will allow you until the vertebral shadow is found. The depth then can be adjusted and decreased to visualize the aorta near the center of the screen. On screen, the vena cava is usually noted to be just left to the aorta. This corresponds to the patient's right side when the probe marker faces the patient's right. Because it is a low pressure system, the vena cava often appears triangular or teardrop shaped. The vena cava may be pulsatile because it is close to the abdominal aorta. There are important ways of differentiating between the IVC and the aorta. And this may seem straightforward, but a few points are worth remembering. Of course, holding the probe marker to the patient's right will generally reveal the aorta on the right side of the screen, the side without the probe marker, thus indicating the patient's left. In addition, the aorta is a thicker walled structure than the vena cava and often develops calcification as a sequelae of atherosclerotic plaques. Thus, it may appear brighter echogenic wall. The aorta is generally round, while the IVC is often elliptical or teardrop shaped. The superior mesenteric artery will generally be visible proximal to the aorta immediately, not the inferior vena cava. The aorta is actively pulsatile. However, as mentioned, transmission pulsation to the IVC from the aorta and the right ventricle can make this distinction difficult. The aorta is not compressible with a probe pressure, whereas the vena cava is. The normal aorta tapers as it progresses distally, whereas the vena cava gets somewhat larger as it approaches the renal vessels. Finally, with deep inspiration or sniff test, the IVC will change caliber, whereas the aorta will not. So these are just few points on how to differentiate between the aorta and the IVC. This is a still image of the same ultrasound clip demonstrating the aorta and the IVC. Starting with the transverse evaluation of the abdominal aorta, you will start proximally positioning the probe in the transverse orientation with a probe marker to the patient's right or at 9 o'clock. The probe should be in the epigastric area just distal to the subxiphoid process and perpendicular to the patient's abdominal wall. Follow the aorta distally until it bifurcates. We will go through a series of ultrasounds representing the abdominal aorta at each of these 5 key elements, starting with the transverse proximal view at the level of the celiac trunk. Starting proximally, positioning the probe in the transverse orientation, probe marker is to the patient's right. The probe should be in the epigastric area just distal to the subxiphoid process and perpendicular to the abdominal wall. When scanning the proximal aorta, the left lobe of the liver is often included in the field. The most proximal level of the abdominal aorta includes the celiac trunk. However, it can often be difficult to get a view this proximal and to visualize the celiac artery. Clinically, it is exceedingly rare to have an isolated abdominal aortic aneurysm that only involves the abdominal aorta from the celiac trunk to the superior mesenteric artery. So it is not essential that this branch is visualized for screening purposes. This is a still image representation of the transverse proximal aorta at the level of the celiac trunk. And again, the appearance of the hepatic and the splenic artery arising from the celiac trunk looks like a seagull, and thus this view is often called the seagull sign. The gastric artery branch is rarely seen with the ultrasound. Moving a little bit distal, still at the proximal abdominal aorta at the level of the superior mesenteric artery, the proximal view with the bright echogenic superior mesenteric artery just anterior to the abdominal aorta. This is the second branch of the abdominal aorta. It's typically located 1 centimeter caudal to the celiac trunk, and the SMA runs parallel to the abdominal aorta and can be tracked caudally with the abdominal aorta. The splenic vein is seen traveling anterior to the SMA. It is even possible to see a glimpse of the renal vein as it travels under the SMA to fuse into the inferior vena cava. This is a still image of the same level, transverse view of the proximal aorta at the level of the superior mesenteric artery, highlighting the same vessels that we discussed earlier. After evaluating the abdominal aorta, transverse view of the proximal, we're going to move down to the transverse view of the mid-aorta. A transverse view of the mid-aorta is obtained by moving the probe caudally along the midline while maintaining a transverse orientation of the probe. The view lacks a unique landmark, and remember that this is very important location because most of the abdominal aorta are infrarenal, and this portion of the aorta should be thoroughly imaged. Moving caudally, as the probe approaches the umbilicus, the distal aorta is imaged as it bifurcates into the common iliac arteries. In most cases, the bifurcation of the aorta is located at the level of the umbilicus. Careful adjustment of the angle of the probe with regard to the abdominal wall will often reveal where the aorta splits into the iliac arteries. Often, a small rocking motion angling toward the feet will be all is required to image the split. Obtaining a longitudinal view of the aorta is most easily obtained after the proximal to mid-aortic view positions. However, it should be viewed as distal as possible given the higher rate of abdominal aortic aneurysm distally to the renal arteries. Begin by locating the aorta in the short or transverse plane, then slowly rotate the probe 90 degrees with a marker towards the patient's head to obtain a longitudinal view. Again, careful side-to-side adjustment of the angle of the probe with regard to abdominal wall to ensure the aorta's greatest diameter is visualized. This is a still image demonstrating the abdominal aorta in a longitudinal view. The same proximal branches, the celiac and the SMA, should be seen in the longitudinal plane. Again, move cephalad to caudad as you can see the entire length of the vessel. The normal abdominal aorta is less than 3 centimeters and it tapers down distally. The appropriate documentation will include a caliper measurement of the proximal, middle, and distal aorta. Measurement should be taken in the transverse plane to limit the tangential effect of underestimating the diameter on a longitudinal image of the aorta. Always remember to measure outer wall to outer wall. It is better to overestimate in this case rather than underestimate. In this graphic representation, remember that the abdominal aorta is a tubular structure, and it's being imaged in a plane of the ultrasound beam. Thus, the transverse view is more accurate in terms of ensuring that the true cross-section of the aorta is visualized. When longitudinal imaging, it is easy to see how a falsely small cross-section of the aorta could be measured if the plane of the beam is just off midline. The reason to obtain a longitudinal view is in order to ensure that you don't miss a saccular outpatching of the abdominal aortic wall. This is an example of the importance of measuring outer wall to outer wall, because a mural thrombus or a plaque in the lumen may underestimate the size of the abdominal aortic aneurysm. Like you can see, the true size of the aneurysm is 3.4 centimeter. But if you only measure the inner wall to inner wall, you will estimate that the abdominal aorta measures 1.5 centimeters only. There are two types of aneurysms. There are the fusiform and the saccular aneurysm. The fusiform aneurysms are much more common compared to the saccular aneurysm. They involve dilation of the entire circumference of the affected segment of the aorta, while the saccular aneurysm is asymmetrical outpouching of the aorta. It's like a sac. And these are ultrasound image representation of the different type of abdominal aortic aneurysms. Let's go through some examples. So what do you think? This is a transverse view of the mid-abdominal aorta showing a 4.5 centimeter aortic aneurysm. Note the blackened center, which is the lumen, is the only area through which blood flows. The thickened outer dimension of the aorta is the result of a clot and atherosclerotic plaque that are adherent to the wall. How about this video? So this is a transverse view showing a large abdominal aortic aneurysm with an endovascular stent. This is the hyperechoic white structure within the lumen, and a mural thrombus with atherosclerotic changes involving the abdominal aortic wall. Here is another still image. It is a longitudinal view demonstrating a 4.5 centimeter abdominal aortic aneurysm. Let's go through this case. This is a 68-year-old male who came in with flank pain. Obviously, flank pain in a 65 or older is a red flag. A bedside ultrasound was performed showing hydronephrosis, significant hydronephrosis on that side. If you can see that the renal pelvis is dilated and filled with this fluid, which appears as black anechoic. Because of the hydronephrosis, the abdominal aorta was examined, and this was demonstrated. So this scan shows a large abdominal aortic aneurysm. So remember, 65 years or older male presenting with flank pain, always think and rule out abdominal aortic aneurysms. Where does the blood go if the abdominal aortic aneurysm ruptures? Ruptured abdominal aortic aneurysm most commonly occurs into the retroperitoneal space, and that may tamponade before the patient becomes unstable. Unfortunately, ultrasound does not reliably identify a retroperitoneal bleed. An abdominal aortic aneurysm occasionally ruptures in the intraperitoneal area, with free fluid rapidly identified by ultrasound. In this case, you can see this is actually a patient who came in with a PAA arrest, and the patient had a history of an abdominal aortic aneurysm that was not repaired. A fast exam was performed and it shows large amount of free fluid. It is assumed that the patient arrested from hemorrhagic shock because of ruptured aortic aneurysm intraperitoneally. This is particularly ominous with a 100% mortality rate. A number of studies have been published on how good are we in detecting abdominal aortic aneurysm. The studies have shown that emergency physician performed ultrasound have a sensitivity of 94 and a specificity of 100%, and a regression of emergency physician performed ultrasound for a AAA diameter was strongly correlated with a radiologist. That means we can do the scan, but we need to be trained and we need to practice. An aortic dissection with a floating intimal flap may be occasionally seen while performing an ultrasound to rule out abdominal aortic aneurysm. So in this scan, you can see that there is this intimal flap within the abdominal aorta, both in the transverse and the longitudinal view, making the diagnosis of aortic dissection. There are a number of protocols that are published on how to incorporate ultrasound of the abdominal aorta into your clinical evaluation. So if you clinically suspect an abdominal aortic aneurysm, you perform your ultrasound exam. The key questions to answer is the abdominal aorta greater than 3 cm? And if the answer is no, then abdominal aortic aneurysm is ruled out and you should be looking for other reasons for the patient's presentation. However, if you detect an abdominal aorta greater than 3 cm, you should assess the patient's hemodynamic stability. And if the patient was hemodynamically stable, then further testing is indicated to further evaluate the pathology. However, if the patient is hemodynamically unstable, a stat vascular consult is recommended and a stat type and screen as well as cross-match for blood because the patient might rapidly become hemodynamically unstable and leading to cardiovascular collapse. Note that the test is most useful in a stable patient with an abdominal aortic aneurysm is excluded via technically adequate study, or in an unstable patient in whom a large abdominal aortic aneurysm is found. Further imaging is warranted for any technically limited bedside study or a stable patient without a clear diagnosis. There are a number of challenges when performing an ultrasound of the aorta. The two most important ones are finding bowel gas or larger body habitus. Imaging through bowel gas usually originate from the transverse colon. As seen here in the video, there's bowel gas obscuring the view of the abdominal aorta. If the bowel is encountered, apply steady pressure by pushing towards the patient's back with the probe. The bowel may be effectively compressed or undergo peristalsis. You may also try to jiggle the probe to move the bowel aside. Another alternative is to fan through the window between the loops of bowel. This is accomplished by establishing a good sonographic window just cephalad to the area obscured by the bowel and tilting the probe towards the feet. Similarly, find a window just caudad to the obstructed area and angle the probe towards the head. Obesity is another challenge that can be addressed by asking the patient to lie completely flat. Have the patient flex their hips and knees to relax the abdominal wall muscles. There are a number of pitfalls that you can face when you scan for the abdominal aorta. Most commonly is the confusion of IVC with the aorta due to the transmitted impulses. not measuring the external diameter outer wall to outer wall, because it's important to overestimate rather than underestimate. Measuring in a longitudinal image can underestimate the diameter if not measured in a true cross-section. Not visualizing the bifurcation of the iliacs, as well as not realizing that the abdominal aortic aneurysm can cause hematuria and hydronephrosis. Again, remember, males greater than 65 years old with flank pain always screen for abdominal aortic aneurysm. So this is a summary of how to perform point-of-care ultrasound to evaluate for the abdominal aortic aneurysm. So remember, you will start proximally in a transverse view and you will change to a longitudinal view. And there are 5 key locations that you want to evaluate the abdominal aorta. The proximal aorta in the transverse view, the mid-aorta in the transverse view, and the distal aorta transverse view to the iliac bifurcation. And then you will get a longitudinal view of the entire abdominal aorta. An abdominal aortic aneurysm is when the abdominal aorta is measured outer wall to outer wall and the diameter is greater than 3 centimeters. This study can save lives and can make a big difference in the patient's care in the emergency department. So go and learn and scan some aortas. Thank you for your attention. Here are the references I've used for the presentation.